Good morning, everyone. I'm presenting on behalf of Medicine 2. My topic today is when the cycle trips. This is a 62 years old gentleman from Tiruvannamalai. The presenting complaints is he came with recurrent episodes of altered sensorium in the form of depressed sensorium for around 5 weeks with recurrent episodes of vomiting. So if we go back to the history, he was apparently well 5 weeks back. He had an probable ACS. He was planned for CABG. So he was hospitalized elsewhere. At the first episode, he had recurrent episodes of vomiting in the form of non-bilious, non-blood stained, non-projectile vomiting with food as content. Followed which he also had altered sensorium. In the form of he had decreased verbal output, excessive daytime drowsiness, and somnolence. And at that time, they thought probably it could be due to dyselectrolytemia. It was corrected, and followed which the patient improved. And so next episode happened post CABG. He was constipated. He was hospitalized elsewhere. Again, he had a similar complaints, recurrent episodes of vomiting with altered sensorium. So this has been happening episodically over the past 5 weeks. But there is no negative history, like there's no history of fever, headache, night sweats, chills, seizures, focal neurological deficits, or neck pain. There is no history of decreased urine output or burning micturition. There is no history of jaundice, abdominal distension, hematemesis, or melena. There is no history of breathing difficulty. Past history wise, he is a known diabetic for 7 years on oral anti-diabetic drugs. There is some past history of rheumatoid arthritis for the past 15 years, but he was not on any medication during presentation. And his current medications were aspirin, clopidogrel, and teneligliptin. Personal history is he doesn't have any addictions and he consumes mixed diet. So on examination, when he presented, he was conscious, was not in any obvious distress, but during the hospitalization, course of hospitalization, he was drowsy and required some external stimuli to arouse. And he was disoriented to time, place, and person. And there is no pallor, icterus, clubbing cyanosis, pedal edema, or lymphadenopathy, and was afebrile. Vital signs, it was almost hemodynamically stable. Pulse was 88, 98 per minute. Blood pressures were 138 per 80 mmHg, and respiratory rate is 18. Coming to CNS examination, at that time, he was conscious and oriented, but he doesn't have any other focal neurological deficit. There are no signs of nuchal rigidity. His bilateral plantars were plexor, but other than that, he had a constructional apraxia and a flapping tremors. And going to other system examination was grossly normal. So in this is an elderly gentleman, had some past recurrent episodes of vomiting and some history of diabetes was there. So initially we thought it could be probably a metabolic encephalopathy, like hepatic or a uremic encephalopathy, but per se the patient doesn't have any hepatic or renal complaints. Or dyselectrolytemia like a hypoglycemia, hypo or hypermagnesemia. He was constipated, whether he was given any magnesium containing laxatives or hypokalemia or any drugs. But the patient, we asked repeatedly, he was only on those three drugs. Or does he have any structural brain lesion? So we went ahead and done the basic blood workup, which showed his HB was 12, WBC is 6,700, his platelets were 2,77,000. His liver function test and renal function test were grossly normal. And he doesn't have any significant dyselectrolytemia. He had a sodium of 131, potassium was 3.5, bicarb was 26, ionized calcium is 4.3, and GRBS at presentation is 226. Thus, the thyroid and cortisol levels are also within limits. So in this time, actually, we are stuck with. So at that time, we had a very significant family history. We didn't do any CT at that time. There is no any CSF analysis. But one among the family, they had his sister had similar symptoms around 55 at her 55 years of age, and it was told that she had high ammonia levels. But other than that, there is no other nil significant history in their family. So in this, since she had high ammonia levels, we thought of sending ammonia in this patient. So when sending ammonia, so his ammonia was also elevated with 495 microgram percentage. So we thought of what could be the possible reason for a hyperammonemic state. Liver failure, he doesn't have. And other things like we thought of like, does he have any acquired urea cycle disorder or like a portocaval shunt? Or is there any catabolic states like a steroid therapy? Does he have any GI bleed or myeloma? Or any TPN was given, or is there any increased nitrogen supply or post-TURP surgeries? Usually post-TURP, doing TURP surgeries, they'll be giving glycine. So is there any increased nitrogen supply or any drugs? He was not on any drugs. There is no catabolic state. There is no increased nitrogen supply. There is no signs of liver failure. So we thought we will work up for a urea cycle disorder. So it was worked up for a urea cycle disorder. So we send urine organic acid, but doesn't show any significant abnormalities. Urine orotic acid was sent, which were within limits normal, but serum citrulline we sent, which was low. And we also sent the other serum amino acids, the important ones I have highlighted, which was grossly normal. So in this state, so he had a hyperammonemic state, had low citrulline, and normal orotic acid levels, we come to a diagnosis of he had a probable urea cycle, late onset urea cycle disorder, probably a CPS, carbamyl phosphate synthetase 1 deficiency. So I want to brief us short about urea cycle disorder. So if we see a urea cycle disorder, it's an inborn error of metabolism. Usually it will be a neonatal presentation. So if they have complete deficiencies, it will be like a failure to thrive. They'll present like hypoammonemic coma. But in case if they have partial deficiencies and if they survive, usually they will grow with neuropsychiatric symptoms, GI complaints, and there will be failure to thrive. They can have any dermatitis and fragile hair like trichorexis nodosa. And very important and concerning here is late onset presentations of urea cycle disorder associated with partial enzyme deficiencies may occur at any age with up to 10% and predominant being the ornithine transcarbamylase deficiency. But if we see, most of them are autosomal recessive inheritance except the ornithine transcarbamylase deficiency, which is X-linked. So there are other inborn errors of metabolism which also can present with hyperammonia like organic acidureas, beta oxidation defects, pyruvate carboxylase deficiency, and hyperinsulinism, hyperammonemia syndrome. So this is just a short history about, just a brief about the urea cycle. So in here, usually an ammonia, it binds with carbon dioxide. The help of energy and with the help of enzyme named carbamyl phosphate synthetase 1, it forms carbamyl phosphate. All of this process takes place in the liver cytoplasm and also in the mitochondria. So meanwhile, this carbamyl phosphate, it binds with ornithine. And with the help of enzyme ornithine transcarbamylase, it forms citrulline. So in here, actually, he had a low citrulline. So we thought the problem is either it is an ornithine transcarbamylase deficiency or as an CPS1 deficiency. So if it's in differentiating one is if there is a CPS1 deficiency, if there's a OTC deficiency, the carbamyl phosphate will be more. So they will be diverted to an alternative pathway. So there will be a lot of orotic acid. Meanwhile, if there's a CPS1 deficiency, the orotic acid levels will be normal. So what will usually trigger a patient? So it can be a rapid weight loss, poor nutritional intake, if there is a GI bleed, even postpartum hemorrhage, and post seizures, if there is a dramatic increase or even a dramatic decrease in habitual protein intake, malabsorption syndrome like a starvation, so that there will be excessive protein catabolism or any medications affecting protein catabolism or any surgeries, chemotherapy, especially valproic acid, carbamazepine, phenytoin, and chemotherapeutic drugs, all those can be a trigger. So any stress or catabolic state can be a trigger for this urea cycle defect. So clinical manifestation, if we say, predominantly they will present like a neurological symptom. They can have an encephalopathy, they can present like a metabolic stroke, seizures, or a transient visual loss, or a psychiatric symptom. Acutely, they can present like mania, hallucinations, schizophrenia, or chronically they will come with personality and emotional changes or behavioral disinhibition or automatism, or like a GI, chronic GI complaints like nausea. They will have cyclical vomiting and progressively poor appetite, especially after having a high protein diet. And significant one is there will be an episodes of signs and symptoms, and the neurological outcomes is related to the extent and to the duration of hyperammonemia. Earlier the diagnosis, the better is outcome. So this is one of the article. Actually, they looked into around 40 cases of late onset urea cycle disorders. They found that predominantly most of them they have a confusion, conversion, like a neurological manifestations followed by vomiting and GI complaints. So this was already I explained like how to normal orotic acid level and being high orotic acid levels. And whatever it is, the enzyme bioassays will help in diagnosis. But for the definitive diagnosis, we have to go for a genetic testing. So the treatment and our goal should be, we should reduce ammonia production and meanwhile accelerate its elimination via alternative pathways. So starting with dietary management, you should start with a low protein diet. So, but in the acute state, we should minimize the protein intake temporarily. But meanwhile, we should provide them energy to meet their metabolic demands. So if the patient can take orally, we can give them high energy, free feeding regimen. But if the patient has recurrent episodes of vomiting or unconscious, we can give IV glucose or IV lipids. And how long are we going to deprive them of a protein? Usually the protein should be reintroduced because their metabolic demands has to be met when ammonia returns to less than 100 micromoles per liter. So ideally the period of protein-free nutrition should not exceed 24 to 48 hours. But meanwhile, in a long term, as I said, there should be some amount of protein. So there should be a low protein diet. We should supplement them with vitamins, minerals, and essential amino acids. So next, other important and acute state is ammonia scavengers. Very important particular one being sodium benzoate, sodium phenylbutyrate, or sodium phenylacetate. So what they does is they bypasses the urea cycle. So they usually, if we take those drugs, they can cause mucositis and gastritis. So usually they are split. They have to be taken 3 to 4 times a day and has to be taken with a lot of fluids. And if we see PBA, they can then decrease your taste. They can cause disagreeable body odor, decrease your appetite. And there has been noted because of this, since they divert the pathways to some other ways, so they can have low albumin levels. And if we on long-term treatment, they are also known to cause renal potassium loss. So hypokalemia is one of the expected dyselectrolytemia which has to be followed up. So this I what I said. Usually ammonia will go to when ammonium they are going into alternative pathways. In such case, so the benzoate, so when it is converting the glycine to hippurate and it gets excreted in urine. Meanwhile, phenylacetate, it is converting the glutamine into phenylacetylglutamine and gets excreted in urine, so that the body ammonia levels go low. So this is overall dosages for long-term treatment. So in our patient had a carbamyl phosphate synthetase 1 deficiency, can give usually 250 mg per kg per dose, up to a maximum of 12 gram per day. And in our patient, there's other option is sodium phenylbutyrate, butyrate, and other is L-arginine. So usually we can give at a 2.5 to 6 gram per meter square per day, up to a maximum 6 gram per day. So in our patient, we gave 3 grams BD, we divided and gave. So what about the use of hemodialysis? If a patient presents an acute hyperammonemic patients, so if the ammonia levels are greater than 500, the recommendation state to start them in hemodialysis. But if at lower levels, if they are resistant to a medical therapy, and if the patient is symptomatic and there has been progressive increase in ammonia despite starting treatment, you should consider hemodialysis. But at present, if we see, there is no role of gene therapy or an enzyme replacement therapy for late onset urea cycle disorders. So this is just a reference about when to start hemofiltration. So take home points is in our patient, family history is very mandatory because we're able to come to the diagnosis after getting the family history. And whenever, if there is an acute unexplained encephalopathy or an acute psychiatric illness at any age, we can consider late onset urea cycle disorder to be one of our differential. And trigger being most, it is following a catabolic state, following a operation, or following a surgery, or following a high protein load, whatever it can be a trigger. For the definitive diagnosis, we need genetic testing. And our goal of treatment has to be like a low protein diet, and we have to supplement with vitamins and essential amino acids. And ammonia scavengers, although they have side effects, if taken at recommended doses, it is safe. So back to our patient. In our patient, actually, we give low protein diet. We gave sodium benzoate, loading dose followed by maintenance dose. And we gave IV glucose, L-arginine, carnitine, and vitamin supplementation, lactulose. We have also sent for a genetic test, which is awaited. So after the start of all those, the patient ammonia gradually improved and the patient symptomatically improved. Thank you all.
Thank you, Akash, for that nice presentation. Any questions from the audience?
For the PGs here, can you first approach what are the most important causes of recurrent vomiting that we should be thinking of, so that we don't send ammonia as the first line panel when we're thinking of vomiting?
Recurrent episodes of vomiting, sir. Either he can have gastritis, or so either it could be just a gastritis, or does he have any adrenal insufficiency? We can think of the patient has recurrent episodes of vomiting, and any dyselectrolytemia, sir, can predispose a patient hyponatremia. They can present as recurrent episodes of vomiting. Any structural, if there is a raised intracranial tension, all those.
So it's good presentation. For the registrars, make sure you approach it systematically, approach vomiting with the history examination. Look at the common causes first. I don't know if you didn't have that history, whether we would have still gone for ammonia level, but it's an excellent presentation and you consolidated. Maybe you should think about how to suspect it if you don't.
Probably because the patient had some flaps. That was the reason why.
The sister actually, she was diagnosed with proximal urea cycle disorder, sir, in neuro. Yeah, so that's why actually we went ahead with that, chased it.
How is the sister doing?
Sorry, sir. I didn't see the patient, but it was told the sister expired due to some reasons.
So that is the important bit, because in the history of finding a family history of a sibling who had an inborn error or some unusual problem, and then should get you to think of an inborn error of metabolism. And how old is the patient?
Him, sir. 63 years old.
63. So ideally, very unusual age as well.
Yeah, the family history becomes very important in this case. And good that you considered that family history as significant and actually went ahead and did all the ammonia levels. Okay, thank you. Next, Dr. Ramya from Medicine 3.